Hello, my name is Amira Perviz. I'm a PGY2 resident at Creighton University Psychiatry Residency Program in Arizona. The aim of this project was to evaluate psychotropic medications leading to false positive urine drug fentanyl screens. This project was started and overseen by Dr. Sood. Gilbert Ramos provided valuable help in data collection. So synthetic opioids are a primary driver of overdose deaths in the United States. Availability of fentanyl has been on the rise in the last years. Fentanyl is a synthetic opioid. It's 100 times as potent as morphine and currently accounts for a majority of opioid overdose deaths. It has a relatively short half-life, about 3 to 12 hours. It is metabolized to norfentanyl, which is the main metabolite, as well as hydroxynorfentanyl, hydroxyfentanyl, and despropionyl fentanyl. 0.4 to 6% are eliminated unchanged. Patients are commonly screened using urine enzyme immunoassays in clinical settings. Window for detection in urine is generally 72 hours. There is paucity of research on cross-reactivity on fentanyl immunoassays, although there is some evidence that commonly used psychotropic medications can cause cross-reactions. False positive results can negatively affect patient care. So this was a retrospective chart review study which was conducted from February 2020 through December of 2020. Inclusion criteria: inpatient psychiatric population at Valleywise behavioral health facilities in Phoenix, Mesa, and Maryville. In order to be included in the study, patients needed to have a negative UDS on admission. Of note, Valleywise behavioral health uses a standard UDS to screen patients on admission, and fentanyl is not part of this screen. So patients get tested via extended UDS, which includes fentanyl, if transferred to the emergency department only. In order to be included in the study, patients needed to be hospitalized for at least 7 days before positive fentanyl results, and locked facility conditions and COVID-19 restriction on all visitation ensured that patients had no access to substances during the study period. Exclusion criteria: any patient with previous history of opioid use was excluded. After all criteria were applied, there were 3 cases identified with unexplained fentanyl positive assays. So case 1 was a 37-year-old male, history of schizophrenia, stimulant use, cocaine, and methamphetamine, who was transferred from jail on Rule 11 after spending 2 years in police custody. His UDS on admission was negative. 5 weeks following admission, patient required transfer to emergency department due to altered mental status following receiving IM medications, haloperidol, diphenhydramine, and lorazepam, for acute agitation. His extended UDS was found positive for fentanyl. Medications on transfer included clozapine, lithium, and trazodone. PRN medications received within 72 hours of transfer included risperidone, lorazepam, and hydroxyzine. His altered mental status improved with hydration, and patient was discharged back to behavioral health 6 hours later. Case 2 was a 61-year-old male with history of schizoaffective disorder, bipolar type, as well as multiple medical comorbidities, including congestive heart failure, hypertension, type 2 diabetes, hepatitis C, chronic back pain, hyperlipidemia, and obstructive sleep apnea. This patient denied history of substance use. His UDS on admission was positive for benzodiazepines, as patient was started on lorazepam at the Urgent Psychiatric Center prior to transfer to Valleywise Health. Patient required emergency department transfer 2 weeks following his admission due to altered mental status. His extended UDS in the ED was positive for benzodiazepines and fentanyl. His psychotropic medications upon transfer included Depakote, escitalopram, gabapentin, haloperidol, risperidone, and lithium. Of note, patient was on scheduled diazepam, which was discontinued 2 days prior to transfer, which accounted for positive benzodiazepines on UDS. His PRN medication 72 hours prior to transfer included mirtazapine. Patient was diagnosed with encephalopathy secondary to polypharmacy. He was discharged back to behavioral health 2 days later. And finally, case 3 was a 65-year-old female with history of schizoaffective disorder, bipolar type, hypertension, hyperlipidemia, GERD, systemic lupus erythematosus, and type 2 diabetes. This patient had no history of substance use. Her UDS on admission was negative. Following a month of inpatient stay, patient required transfer to emergency department due to tachycardia and upper respiratory infection. Her extended UDS was found positive for fentanyl. Patient scheduled psychotropic medications on transfer included clozapine, benzotropine, flufenazine, and trazodone. Her as-needed medication 72 hours prior to transfer included hydroxyzine. Patient was diagnosed with viral bronchitis, supportive care was provided, and she eventually returned back to behavioral health 2 days later. These samples were analyzed using immunolysis Cephria fentanyl immunoassay. This immunoassay received FDA approval in 2017, becoming the first immunoassay available clinically for detection of fentanyl. Prior to that, fentanyl detection was only available in forensic settings. This particular immunoassay has a cutoff of 1 nanograms per milliliter for fentanyl detection. And in clinical studies, it compared favorably to liquid chromatography mass spectroscopy analysis in both sensitivity and specificity. Multiple commonly used psychotropic medications such as amitriptyline, bupropion, diphenhydramine, fluoxetine, haloperidol, naltrexone, risperidone, trazodone, and venlafaxine are shown to have a possible cross-reactivity, as well as medications such as labetalol, cyclobenzaprine, and meperidine. This table shows a full list of possible cross-reactivities. Here, just for reference, I have chemical structures of these medications. So discussion, our case 1 patient was on risperidone, diphenhydramine, and haloperidol. Case 2 patient was on haloperidol and risperidone, and case 3 patient was on diphenhydramine and trazodone. So each of these patients were on 2 or more substances with potential cross-reactivity. It is unclear, however possible, that the presence of multiple substances had additive effect. So limitations of the study, basically number of patients who received extended UDS was very small, as only patients who get transferred to emergency department were tested using extended UDS. There were no confirmatory tests performed on these samples, as this type of testing is unavailable at Valleywise Behavioral Health and also due to cost. And another limitation was retrospective design. So conclusions of false positive urine fentanyl drug screen can adversely affect patient care. We're talking about inaccurate assumption of substance use, which in behavioral health setting can have implications such as room and contraband checks, restriction on visitation, no outside food allowed, etc. In addition, patient can also risk losing employment, housing, having delays in care, having criminal justice implications, etc. So reflex confirmatory testing is important if positive tests will affect treatment decisions. So as clinicians, we have to maintain a high level of suspicion of false positive fentanyl screen, especially if patients are on psychotropic medications. And these are the references. Thank you.